of the latest studies to show you how we're using a closed-loop system to begin to answer a question that has an impact on everybody that develops diabetes. This is a three-year study. It's actually going to end up being more like a 5-year study that we're doing with Stanford and Yale, and then we've added Indiana and Vanderbilt. And we have finished enrollment. Just last week we enrolled our last patient. So now we have just 2 more years to follow. But it's a 3-year study, or a study where we're looking at 78 brand newly diagnosed patients. And the question is, can we, by putting them on a closed loop system and achieving excellent glucose control in the first days of their diagnosis, get them into the honeymoon faster and preserve beta cells? And that's the question. The tool is the closed loop system. The age range was, it was randomized so that for every 2 people that were in the actual trial intensive part, 1 patient was in the control group and did not go get this. So, okay. And it's been a very tricky study because you have to take brand new parents with this who are, as you all remember, like deer in the headlights, and present this study to them, which is going to ask them, do you want your child to go on a pump and a sensor and into the hospital for 4 days so we can do this? And all of this amount of information. And the surprising thing is we have had just extraordinary families who have said, yeah, we want to do that. I'm not sure I'd be willing to do it, but so my hat's really off to them because they're really taking a big leap of faith to do that when they just have heard that their child has diabetes. Out of all these people that we enrolled about 1/3 of these people, and only 1 was an adult. It says you could have older people, but everybody we enrolled was a teenager or even younger. Our youngest patient was 8 years old. Okay, next. And the aim, as I said, to determine if rapid restoration of metabolic control can improve beta cell life. And we measure that by measuring C-peptide. I don't know if you're all aware of that, but you start giving people insulin, you can no longer measure insulin. You want to know what they're making. And nature's provided a tricky way for us to do that because when the body makes insulin, it makes a compound or a molecule called proinsulin that's bigger. Then it cleaves off a piece of that, leaving the 2-chain insulin molecule. So we measure that cleaved off piece, which is called C-peptide. And it's a direct one-on-one relationship to how much insulin the person is still making. So that's tricky. I like that. And so we measure C-peptide to look if they're still making insulin. And then we want to know, does this change the autoimmune process? And we've drawn a lot of immune markers that I can't tell you the results. They've all gone to the lab and that code won't be broken until the end of the study. Okay? But I can tell you about the study itself. It's based on a study that I won't go into in length, but it was done way back in 1989. Same idea, different technology. Nobody had closed loop systems then. I think the next slide shows a picture of what there actually was. It was called a biostatter. So here's this poor guy. He's in the hospital. Back 2. Yeah. So he's in the hospital here, and he's hooked up to this. Now, this interesting machine here weighs, I don't know, several hundred pounds, and it would draw your blood sugar every 15 minutes or so, maybe every 30 minutes, just like in a lab. It took that much blood, a big syringe of blood. It would read a blood sugar, and then it would go to a pump part of it that would deliver you some insulin. So it was like the first closed-loop system in a way, but not exactly something you'd take out on the playground with you. So go ahead, the next slide. What this group found was, yes, in fact, when they did this, they tended to get much longer duration of C-peptide, a year out even 2 years out, 3 years out. The DCCT showed the same thing, that the quicker you get into good glucose control, the longer your honeymoon is and the longer you preserve your C-peptide. Okay? So we're doing this with the new technology, which is to give us the possibility of letting people then go home with the pump and sensor. They get put in the hospital for a 72-hour period. They go on the closed loop. One of us sits there all day, all night, and watches. And we have, out of all of those 78 patients, never had a single safety issue. We haven't had one significant hypoglycemia. We have not had any safety issues. So that's good news. The other good news is, here's a person 1 week after that. They're 1 week out, and look at their glucose control. This is a continuous glucose monitoring sensor. That's pretty great. Next. This is somebody who's now a month out. And I can tell you that we now have these slides for people who are up to 15 months out. And they remain very good. We don't know what their C-peptide levels are. That's part of the locked information we won't see till the end. But I'll bet you they're still pretty good. So it works. At least it works over the first 2 years that have been tested so far. What we hope is that it will preserve C-peptide and insulin production in beta cells indefinitely. Would that cure diabetes? No, but it would sure, if you could have every patient with diabetes in a perpetual honeymoon on low doses of insulin with this kind of glucose control, that'd be pretty good. And in the meantime, it's letting us test the closed loop system. Because for us, it's the first study that has been day and night, 72 hours on the system. And again, as I said, not one single safety issue. Okay? Yes.
Testimonial to the fact that, you know, as a parent with a child with type 1, you sleep with your ear open all night long. Mm-hmm. Is, with these families going through that, can that be used as testimonial for that as well, or
sure,
I'm not sure.
For like that kind of a system, yes, I think it can, and the FDA is aware of this kind of information. And the other piece that is not in the slide, but that I'd like to tell you is that Medtronic we did this study too with them. They've developed a thing called MySentry, which allows you, if you're on a sensor, to plug a little thing into the wall and then to have a remote alarm wherever you want it, but in your bedroom or something. So that if the sensor goes off and there's an evidence of falling glucose or whatever target you set, you don't have to keep getting up. You will get an alarm that you can hear in your bedroom. Or let's say that you went out and you had, like our family, which was big, anytime you were at a motel, you had to have 2 rooms, you know. And so you wanted to be in one room and your kids in another room, same idea. You can use this anywhere. In fact, it'll alarm loud enough if you want it to that the whole house can hear it. And that system is finished, approved, and will be on the market by the first of the year.
That's only for Medtronic?
It will work with a Medtronic sensor. You don't, yeah. But I'll bet you anything Dexcom won't be very, very close behind. So that's great. I mean, that's not high-tech research, but it's sure a step forward. That same kind of technology, by the way, is going to allow you, and this is under development, to maybe have that information on your iPad or on a cell phone, and to put it, if your car has a GPS screen, you could have on the GPS screen a glucose reading also, or an alarm that tells you if your child in the back seat's becoming low.
Can you also find your kids as far as teenagers from this point of view
yeah,
too?
The locator feature, isn't that what the iPhone has? That I'm supposed to be worried because Apple has been tracking me all this time? I don't know. Okay, well, this is a busy slide. This is the result of the first year of study. It was presented at a technology meeting in London this past winter. And I just want to say, let's look at some of these. People that were below 70. If you're going to be low, it's most likely going to happen at night. I'm sorry, but in the study, you reduce nighttime low. There's no time that's easier to use a closed loop than at night. You're not eating, you're not exercising. In fact, if we could keep all patients with diabetes simply asleep for their whole lives, we could achieve wonderful control. How often are you high? Well, the first day, let's pick the most, let's say above 200. You came in, you were 20% high. By day 2, you're 13%. By day 3, you're 10%. That's okay, that's fine. Let's just go back 1 or 2. So what it's showing is that as you stay in on this closed loop, in fact, you do rejuvenate your beta cells. You do begin to make insulin. It does work. So the closed loop works, and the idea of good control helping your beta cells works too. Well, and this is the same thing, just showing it in a graph form. This is the hyperglycemia, the yellow, and it gets to be very, very small. Okay? I think we're about to close. That's fine. Let's just go to the next one. So we just, in conclusion, this study, which is just one of many closed loop studies, but is a big one that we've been doing for several years, shows that these controllers are safe. They stabilize glucose at diabetes. Within 6 hours of starting the hybrid closed loop, there's a significant improvement in glucose levels. By the 3rd day, the amount of hyperglycemia had reduced from 28% to 8%. Only less than 0.5% were under 60, and less than 0.1% were under 50, so we had very little hypoglycemia of any kind, and as I said, we had no significant hypoglycemia. Nobody developed ketoacidosis.
Yay.
Or even ketones, for that matter. Fine, next, and I think that's it. So the hybrid closed loop system in our study works. It does what it's supposed to do. We told people you can eat what you want to eat. And some of them took us up on it. Some of the teenagers especially. So they often had more than 2 grams per kilo. So we're talking about meals with sometimes 150 grams, 200 grams of carbohydrate. And yet, if we pre-bolused and then used the hybrid closed loop, it worked pretty well. No adverse effects. And now this is 1,100 hours as of January. It's now double that. Okay. And the effect is sustained, as I showed you. It doesn't just happen when you're in the hospital. So the people don't go home on a closed loop. We can't do that. But they go home with a pump and sensor. And that 3 days that they're in the hospital, they have intensive nursing teaching them how to use the pump and sensor. So in a way, they kind of get a year's worth of diabetes education all in the beginning. Okay.
So once this is all studied and safe, what age group are you going to be able to put this on children?
I believe that the issue will not so much be age. That one hopeful thing about this for the FDA is that the FDA is willing for us to study the devices. If they're going to approve them, they'll approve them for us to study even in children. Unlike a lot of the history of medical research where you have to have the adult stuff done, published, absorbed before you're allowed to study children. What we do with some of the studies is we'll start with a group of adults. If that goes well, then we'll go to 18-year-olds and so down. But I think once this is approved, as the pieces are approved, it will apply to almost everyone. I don't think it's going to be very.
So how many more years we got on this?
Okay. We can turn off the show, or leave it, I don't care. How many years do we have? Well, here's the piece I'd like to leave you with. It depends what you mean by the closed loop system. I think the rest of the world already has an important part of the closed loop system. They can prevent hypoglycemia at night very effectively, and it will be maybe 1 or 2 years till we have that piece. I think the next piece will be overnight control, that everybody will feel pretty comfortable with. because we're doing some of those overnight studies. You saw some in Britain. We're going to start some in the US. So maybe 3 years or 3 to 5 years till you can wear the pump closed loop system overnight, and maybe even it'll be pretty useful except for exercise. It's hard to predict because different groups are doing this. Our exercise study is going to be published, we think, in the New England Journal of Medicine pretty quickly, and it's astonishing. One group of people came in, they had to have a glucose between 100 and 140 to start the exercise. They got on a treadmill or a bike. They exercised till their glucose fell to 80. Then they either had the pump with the suspend on, so it turned off insulin, or not. So the group where then we kept exercise, we didn't exercise, and they finished at 80, but we kept watching them for 4 hours. And we didn't want them to drop below 50. If they dropped below 50, we had to feed them. And all of you know that if you're 50, you feel pretty hypoglycemic. And so what happened for them was that the group where the pump suspended, you get down to 80 or maybe a little below, and it comes right back up. It's like the Nike swoosh. The group where there was no suspension of the pump, so they just kept getting their basal insulin, they go down and they stay down or even get lower and lower till they're below 50. So the exercise piece works also. So I mean, maybe I'm pessimistic if I say we do overnight and then exercise. Maybe the studies will come along. I know at the latest meeting, optimists were saying 5 years. My belief is that pieces of this will certainly be available in 5 years. What will be the end result? My personal view is, in the end, what we are going to want is a sensor that can be implanted into the vasculature. And the one that's been developed, you put in through the subclavian vein, and it goes up to the inferior vena cava above the heart. And it has been proven to last for up to 13 years. So it's not like you're doing this all the time, but you might several times in a lifetime have to have the sensor replaced. And then the pump itself will go in the peritoneal cavity, and the two will talk to each other. So then you're not wearing any equipment, you're delivering insulin where it needs to be delivered, and you have a sensor in the vessel, not just under your skin. So you're getting blood glucose readings that are very accurate.
I feel like Vanna.
By the way, the technology research for those kinds of sensors and pumps has been done and approved. It's
Doctor, I have a question for you regarding where you talked about, you told especially the teenagers to eat whatever they wanted.
Oh,
and so I'm just going to kind of paraphrase what my thought is I'm sure that you're probably trying to rush as much as you can carbohydrates and stuff to see how much the body can handle. But on the other hand, it kind of sends a message about, good health, good eating. So help me with that.
Okay.
And then I'll follow up with an FDA
Okay.
question.
Thank you. That's very, yeah, we don't really tell patients all the time to eat whatever they want. You're exactly right. For the purposes of these studies, we do some where we really stress the system by letting them eat a lot. The first patient we had in, who was about a 14-year-old girl, she was our first subject, she had these big brownies and a milkshake. Even with pre-bolusing, I can tell you she became hyperglycemic, and she stayed hyperglycemic for several hours. So from that point on, we no longer really told anyone they could eat absolutely everything they wanted. And we would never tell them to go home with that. So we've redevised the studies. We have different studies where we look at different meal, but specific carbohydrate amounts.
Okay.
And you're absolutely right.
Okay.
It was just as we're willing to let them have a little more freedom to see what the system would do.
Regarding the FDA and the panels that are used to determine whether or not something gets let out into the society and where people can buy it, Is there any way that those panels can sign documents that reflect their conflict of interest, and that that's out in the open, and that hopefully mitigates some of that? Or secondly, the other thought I had is, can't the people on the FDA panels here in the US be kind of traded off and maybe used in Europe, and the Europeans come over here?
Yeah, let me answer I mean, both of those make perfect sense. Our FDA has been singularly unreceptive to research and approval that's been done out of the country. Maybe not research. Medical research, wherever it's done, it could be published here in this country or in the Lancet in Britain, you know. So, but the fact that a thing has been studied by a regulatory agency in Europe, and Europe has, because of the EU, they have one regulatory agency. So if it's approved by that, it's approved for all the EU members. The FDA's view is that they are not tough enough, frankly. The panel question is being investigated. I mean, that is an issue. It's not just an issue for diabetes devices. And, you know, we have really, I have to say, we have one extraordinarily good advocate on our side, and that's our Congresswoman Diane DeGette, whose child has diabetes and who sits on the oversight agency that works with the FDA. And she has